Hello friends, I am Dr. Khalad Jafri. I am CMO at CHS Lucknow. Of late in our previous videos, we have been discussing about how to read the ECGs and we have discussed basic concepts that how we should read ECG. And then moving on to supraventricular tachycardia or more accurately called supraventricular tachyarrhythmias, we have dealt with the most common cause of supraventricular tachyarrhythmia or paroxysmal supraventricular tachycardia, that is AVNRT, atrioventricular nodal reentry tachycardia. And you must be wondering why we have left the ECG in between. We'll talk about ECG as we move further on, because if we ECG is a very vast topic, and if we talk only about ECG, you will be get bored. And study is always better in a retrograde manner. So we'll side by side we'll discuss ECG, which is at this level, entrance level, it is important for you. Now coming back to the AV, now coming back to the supraventricular tachycardia, now we'll deal with the atrioventricular reentrant tachycardia. Now you have to understand that what is the concept of accessory pathway and WPW syndrome. Now what is the accessory? You know that the heart is deployed from the SA node to the AV node, and then to the bundle of His and the Purkinje fibers, and then the ventricles are depolarized. Now in 1,500 to 2,000 people, their accessory pathway is present, and it is associated with a variety of arrhythmias, paroxysmal, paroxysmal supraventricular tachycardia mainly. And these, what are these accessory pathways? These accessory pathways are abnormal connections between atria and ventricles. Between atria and ventricle, between the atrioventricular ring, and some congenital causes are there. Most common of them is the Epstein anomaly. Now, as our um, as our this topic's name is NEET PG Concepts. Our channel's name is NEET PG Concepts. So we will be dealing with mainly we'll be dealing with the concepts, and those concepts will lead to solution of your multiple problems. Now look at this diagram. This diagram is the crux to the understanding of this AV, atrioventricular reentrant tachycardia. Now there are three types, mainly three types, and the most common of it is the orthodromic uh, atrioventricular reentrant tachycardia, as you can see in the picture. Now, uh, what happens there? What is orthodromic? Then there is a pre-excitation. Then there is antidromic atrioventricular reentrant tachycardia. What are these? So, accessory pathway is present in all of these, but in which manner the heart is depolarizing and in which manner the impulse is returning, uh, that is very important. And you can see in the diagram that in the orthodromic atrioventricular reentrant tachycardia, which is the most common cause of this tachycardia, the heart depolarizes through the AV node, and the AV node through the bundle of his and the Purkinje fibers, and this impulse again this reaches through the accessory pathway to the AV node. So this is the most common cause, and that's why PSVT, it most commonly presents as PSVT and narrow complex tachycardia. Other two causes are pre-excitation and the antidromic. Now we'll understand one by one what is pre-excitation and what is antidromic. Now, as you can see that we have discussed orthodromic. What is orthodromic? Now another mechanism is the antidromic, and pre-excited tachycardia is a part of antidromic, in which the impulse passes from the atrium to the ventricle through the accessory pathway, and then from the accessory pathway it goes to the Purkinje fibers, and back from the Purkinje fibers is bundled to the again to the bundle of His, and then to the AV node, and and thus a circular movement is formed. And in the pre-excited tachycardia also, the pre-excited ventricles are pre-excited through an accessory pathway, and AV node is also, so both the uh, it is going through the accessory pathway also and to the AV node, and then coming back through the Purkinje fibers and the bundle of his back to the AV node. So this pathology, this pathogens is very important to understand. And based on this, the ECG features will develop, and then the management part will also depend on the what is the pathophysiology behind this. So you can see that PSVT, which is the most common cause, that is the orthodromic pathophysiology, and the management of the PSVT, as you all know, we have discussed. Now, coming back to now, we'll move to another slide, and we'll see that what are the clinical features and what is the differential diagnosis based on these pathogenetic mechanisms. So, we have seen that in orthodromic atrioventricular oriented tachycardia, it is same as PSVT. We will get a narrow QRS complex less than 0.12 seconds, and in antidromic AVRT, the ECG features will be now in the antidromic and the pre-excited tachycardia. The ECG feature will be a wide complex tachycardia. Now, wide complex tachycardia, this is very important to determine. If on the ECG, in the ECG in the question paper, it is given that it's given that you can see that there is narrow complex tachycardia, then PSVT will be the most common choice. But if the you see the wide complex tachycardia, then it is most likely to be the anticomic AVRT or PXI tachycardia, that is also known as Wolff-Parkinson-White syndrome. Here comes the concept of Wolff-Parkinson-White syndrome, which is very important for you to remember. And you should also know the differential diagnosis of this wide complex tachycardia. That is most common cause is the ventricular tachycardia and the PXI tachycardia. This you must understand. Now, coming back to the treatment part, the management part, you know that the orthodromic AVRT, the ECG also same as the PSVT, and the management is also same as the PSVT. That means that you will give the vagal maneuvers, carotid massage, or adenosine, then intravenous fertility as and veradamil, beta blockers, so all these things. And if it is unstable, then cardioversion. Now, in anticomic AVRT and pre-excited tachycardia, they should be treated as ventricular tachycardia until and unless proven otherwise. Now, this concept is very important for you to understand. Now, the very interesting topic that if this tachycardia is very irregular, it means it is a irregular wide complex tachycardia, and it should be considered as atrial fibrillation or atrial flutter and treated with cardioversion or intravenous procainamide or ibutilide. Now, this concept is very important for you to understand. Now, one very important point I have to discuss, and that is that in the pre-excited atrial fibrillation, you must not use this amiodarone or intravenous adenosine or verapamil, diltiazem or beta blockers because that may precipitate because you will block the AV node and that may precipitate dangerous atrial fibrillation. The heart rate may be increased dangerously. So in those cases, you must not use these agents. Now to summarize, so you must know the concept of accessory pathway and these three pathophysiologies may precipitate because you will block the AV node and that may precipitate dangerous atrial fibrillation. The heart rate may be increased dangerously. So in those cases, you must not use these agents. Now to summarize, so you must know the concept of accessory pathway and these three pathophysiologies which I have shown that in the orthodromic there is antegrade conduction over through the SA node to AV node, bundle of his then the Purkinje fibers and ventricles, and back in the retrograde manner through the accessory pathway. And in the antidromic and the pre-excited tachycardia, the accessory pathway is conduction in the antegrade manner. So this pathophysiology you must remember, and according to this, the ECG features are present, the P waves and the QRS complex, those will be present on the basis of this pathophysiology. And you must not remember only the wide complex QRS tachycardia that is present in pre-excited tachycardia and antidromic conduction. And in the orthodromic conduction, it is the same as paroxysmal supraventricular tachycardia. And so this is very important for you to understand. You can solve multiple questions based on these things. Now, please do subscribe our channel, and so that so that our subscribe may increase, and you may get benefit, and so that I may also be uh, uh, motivated to make more educational videos like this. Thank you.